facet joints are the two additional joints that are not talked about as much when we're talking about spine problems. Patients come in and always want to know how their discs are doing, and the discs are very important, but the facet joints are a very interesting nidus of pain. A lot of discomfort can come from the lower facet joints that can create very debilitating back pain. The facet joints can be injured a couple of different ways. These facet joints can be injured in a type of whiplash type of injury, and in the lower back, rotational injuries can injure these facets. And usually what happens is that these facet joints degenerate similar to the discs themselves, in the fact that arthritis can affect these joints. So as we get older on in life, injuries to the lower back can continue to cause microtrauma to these little hinge joints that we have in our back, and we have at every level of our lower backs, one on each side. So the most common complaint is stiffness in the morning. Sometimes the mobility throughout the day makes them feel better, but in general, standing for long periods of time causes significant discomfort that sits just right there in the lower back where the facet-mediated pain is. And sometimes you can have the referred pain into the legs as a result of that, but it's usually alleviated when you sit. Typically with facet-mediated pain on the initial evaluation, we're doing an exam localized to try and push on the facets themselves and see if that causes discomfort. We have the patient lying down on their stomach. In addition, the other component is functionally standing upright, and usually extension with rotational components can load these facets. It's not absolute, it's not a definitive diagnosis with doing this, but it really can help identify that area as being the possible cause of the discomfort. The imaging studies are quite important in this circumstance. The idea is that on an initial evaluation, you're obtaining x-rays to evaluate to make sure that there isn't a dislocation or fracture, but also to take a look and see what role the arthritis may be playing in the patient's problem. And we can take a look at the facets themselves and find out, is there a lot of arthritis of these facets? Now, because facet pain can also radiate sometimes into the legs, the idea is that further imaging study like an MRI can be performed, not only to take a look at the facets, but also to make sure that the nerves are not getting impinged before they leave the spine. Treatment options for facet pain can include anti-inflammatory medications, such as non-steroidal anti-inflammatory medications. Occasionally we do use steroids, either taken by mouth, or we can actually do injections into these little facet joints. This has both diagnostic and therapeutic benefits, meaning that when we do the injection into the facet joint and we get good pain relief, that further confirms that this is where the pain is coming from, and by doing an injection into the joint with a steroid as an anti-inflammatory, that is the treatment. The idea is that once we get that inflammation and irritation of the facet down, then we can progress the patient into a functional rehabilitation program to address what causes the degenerative issues of the facets to begin with. Inevitably, one option, though, is that when these facets themselves are significantly irritated and the injections themselves don't always last for a long period of time, we can do higher level interventional procedures to identify and burn the actual nerves themselves that go into the joint so the patient does not have discomfort to this joint any longer. One additional option for facet-mediated pain is to try and decompress this area. Traditionally, we decompress or do traction on the spine for disc-related issues, but unweighting that joint temporarily can help alleviate the pain for patients so that we can once again progress again with a physical therapy program. So intradiscal decompressive therapy, or IDD therapy, is essentially the new form of traction. Traction has come a long way. We used to admit patients to the hospital for this and have a big bag of sand or water at the end of the bed, and patients would be in traction for a week or two. Now everything is high-tech, thank goodness. So we have a suite where we have a high-tech computerized machine that can actually pull at a very precise angle to distract the spine right where either a disc is herniated, significant degenerative changes exist, zygapophyseal arthropathy is present, that's the facet-mediated pain, and by decompressing this area, we can give significant pain relief. It improves vascularity and healing up of the damaged tissue in this area. It's very important that after the patient gets the initial treatment to try and reduce the irritation of these facets themselves, for them to get an education about what causes these problems. That's usually the role of the physical therapy. But inevitably, it's very important for the patient to continue on with their exercise program that's been very individualized for their problem so that they don't have problems in the future.